Well, good morning. This is always quite an honor to speak in front of this group because many of my mentors that helped me get started in this, Brian and Sean, it's been a challenge. I heard a lecture. I was just talking to Sean about this, and clear back in like 2006, I heard him talk about nerves can be identified on ultrasound, and it was like a huge light bulb went off in my head, and I was like, wow, I have to learn this. And so when the committee asked me to speak about the new frontier, I'm like, what new frontier? I've been doing this for some people in this audience have been doing this longer than I have. And so I kind of thought about how did I want to bring up this topic, and what am I doing that's different than everybody else? So I'm trying to go back a little bit to what I covered last year, and then some new insights that I've gained. I do want to thank Brad Fullerton for opening my eyes into the fascia. As an MD, I got zero training on the fascia. And I'm hoping to sort of bring a bunch of things together in terms of hydrodissection, where we're going, what we need to learn, and different treatment options. So raising the bar, we're all there's a lot of us that are doing hydrodissection, but how do we push the envelope? How do we keep pushing that bar higher and higher? We were at 16 feet last year, and now we're going to try to make 17 feet. And then how do we make 18 feet the next year? And so I'm constantly trying to challenge myself and push myself to make myself better at identifying nerves and finding smaller and smaller and smaller nerves, because that's the key, is being able to find nerves that haven't been found before. And then what things are in our way? What's holding us back? What's limiting our practice or our ability to identify these challenging nerves? Last year, I sort of, with hearing Brad talk about the fascia, it sort of opened up a new paradigm for me to shift in terms of trying to look at nerve hydrodissection in a new way. And I look back at myself, and we all have patients that do great with nerve hydrodissection. We go in there, we do a superficial fibular nerve, we blow out the curl fascia, and we pound our chest and say, I made that patient better. But some people come back and say, Doc, that didn't work. And why didn't it work? Is I guess the question. And the fact is that nerves frequently travel through fascial planes, and so our fascial planes are a part of why hydrodissection may or may not work in some individuals. And I like I've sort of formed this term, neurofasciopathy. And I think if we start thinking of nerve entrapment as a neurofasciopathy and not just as a nerve entrapment, it changes the paradigm, and it changes how we look at these nerves and how we can treat these nerves. So I like to use a patient to help explain my thinking. This patient's a 34-year-old female that flew to me from North Carolina. And it's not easy to get to Helena, Montana. It's like 3 or 4 flights. And she had a 2-year history of shoulder pain. She has an autistic child, who's about 9 years of age. He's a pretty good-sized kid, and she's a little 5-foot-tall woman. And her son got scared and was running towards a busy street, and she hung on for dear life. And she felt a pop in her shoulder. It was extremely painful, but she hung on. She got her son settled down, and then she had a shoulder that didn't work. She had a massive workup over a year and a half. She had at least 3 shoulder MRIs, 2 cervical, and an EMG that's been normal. She's been to the Mayo Clinic, the Cleveland Clinic. She's traveled all over the United States trying to get an answer, and everybody just pats her on the back and say, the MRIs look normal. You're nothing wrong. You just have a stressful home life. And she's desperate for care, and she eventually found someone that diagnosed her with scapular detachment syndrome, had this massive surgery for that, and it didn't make a difference. Her scapular winging was slightly better, but overall her pain was still the same. So the differential diagnosis for scapular pain is huge. Those of you that came to the scapular workshop hopefully saw a much longer list than this, but the list goes on, and there's a lot of different things that can create a burning sensation over the scapula. And if you see a neurosurgeon, they all think it's cervical radiculopathy. I'm hoping to sort of discuss different aspects of nerve entrapment in the shoulder and things that you might want to look for. So the journey of this patient was significant. And if you Google the web for just type in burning scapula, you'll find chat groups, you'll find all kinds of web pages, and it's crazy what's out there. And these patients are desperate for help, and some of them are incapacitated by this burning scapular pain. This is an example of someone with this massive scar here for scapular detachment surgery. And they're all searching. They come into my clinic and say, I heard you can help me. And it terrifies me when they say that, I hear you can cure me. They've all had quite a journey. They've had cupping, they've been injected, they've had prolo, they've been manipulated, they've had acupuncture, they've had chiropractic care, and then many of them, unfortunately, have had neurogenic thoracic outlet surgery. I have tons of these patients that come in and see me, and they've had bilateral thoracic outlet surgery, and they're no better. That burning sensation to the back of the scapula is still there. So is this just really a disease that's multifactorial, or we just don't really know what in the hell it is? And that's the challenge, and I started challenging myself to that. I felt that it was nerve-related, and that I just needed to find a new way to identify what nerve this was and what the nerve problem was. And it sort of helped me develop new exam techniques. We didn't have exam techniques that I learned that helped me to identify what this really is. And so I developed new exams. Do we need new imaging techniques? So in the beginning, I couldn't find a way to use high-resolution ultrasound imaging to determine what was going on. So I developed new approaches to identify what I thought was wrong. And then obviously improving technologies and new treatment options are what I was searching for, and what ultimately hopefully helped this patient. I love this slide because it's, we all have, even we like to tease the orthopods, if all you have is a hammer, everything looks like a nail. But sometimes, and even in regenerative medicine, we can be guilty of that. And this gentleman has lots of different size hammers. And I wanted to make sure that I wasn't trying to apply my differential of nerve disorder only to this. So I had to rethink the entire process and looking at the fascia as well as other examination techniques and then imaging techniques to try to solve this problem. So I went back to the basics a couple years ago. I went back and read everything I could about the scapula. I developed a new history that was important to me in physical exam. Scapular motion, I talked briefly about that, last year was the key to this. You can see I've made lots of drawings on these individuals, and I can tell you, I can look at these little drawings, and I know what nerve's involved. But I'm not always correct. In this individual, we were all looking at this saying, oh, that's easy. He has long thoracic nerve injury. Now, let him come down. So that's long thoracic, right? Well, watch him abduct. He wings also with abduction. What in the hell's that? You're not supposed to wing with abduction. So I had to come up with new ways to help identify that, and new ways to look at this from a neurologic standpoint as well as a fascial and muscular component. I see people come to my clinic now, they have significant atrophy of the infraspinatus here. You can see all kinds of stuff going on. How am I going to evaluate this? And so I developed a standardized approach to scapular evaluation. We covered that in the workshop with Brad's help. You have to look for atrophy, depressed anterior rotated shoulder. You need to make measurements where the scapula actually is in relationship to the spinous process. And you just have to have a thorough, comprehensive exam. And essentially you need to develop a protocol for yourself to look at this stuff. We're all, just kind of a review, we're all familiar with long thoracic. The dorsal-scapular nerve here is involved. You can tell that by the lateralization of the medial border. This side's normal. Those lines, when you go in forward flexion or abduction in 90 degrees, those lines should all overlap. But once they stop overlapping, you can sort of start to have a hypothesis on what nerves. Then if you have a nerve that you think is the problem, you have to learn how to find that nerve. And so there was really nothing in the literature about finding some of these nerves, and you have to, with great patience and practice, learn to identify many of these small trunks. And what's really interesting is in the literature, there's lots of incidences where these nerves share combined trunks from the brachial plexus. It's in the small details of many of the articles in the literature, but not well publicized. And then don't forget that in your examination, you have to rotate their head or side bend their heads to challenge this, the spleen, middle scalene and anterior scalene to see what happens. And so when they're looking straight ahead and you do your shoulder exam and scapular exam, everything looks good. But if you rotate them or side bend, you may find something different. And then I came across this article that helped in my journey. If you look at intraneural blood flow and you stretch the nerve 6%, no change in the blood flow of the intraneural component. If you stretch it 11%, it's diminished by 50%. And with a 16% stretch, you have completely obliterated blood flow to that nerve. So it only takes a 16% stretch of a nerve to make changes to that nerve. And then there's another article that changed my thinking about nerves. So think of the little child's toy that's a finger trap. We stick our fingers in it and we pull it apart and the center collapses. What if nerves are anchored at two places? They're anchored in the neck and then anchored distally. We're compressing that nerve somewhere in the middle. Where's the middle? And that's the challenge, is finding that middle with your ultrasound so you can address that middle and identify areas for treatment. So most of these patients have all had a massive workup for cervical radiculopathy. And I like this term neurofasciopathy because it's a mixed disorder. You may have a tethering of a nerve at some distal place, but if you decrease its blood flow, you create an inflammatory response, and then it causes thickening of the fascia, which creates more tightening to the nerve and more adhesions, and so forth and so on. And because the less long thoracic nerve, the dorsoscapular, spine accessory, and the suprascapular nerve all travel through fascial planes in the neck, there's a landmine of targets up here. And it's really all about fascial restrictions in the neck, which we'll get to in a minute. Kind of a step back review from last year. Remember that anterior scalene has multiple attachments, and between these attachments is a fascial tissue, and the nerves can travel through, the branches travel through those fascial openings. Also realize that in normal netter's anatomy is less common than having a significant variation, which I described last year, where the roots get tangled up in the anterior scalene. And it's those tangling up of those nerve fibers that creates an overall tension to the nerve, creating a downstream effect. So as the nerves travel through the fascia on their pathway to their muscular innervation, anything that interferes with their normal gliding through the fascial plane can create nerve pain. And so that created a journey of how to evaluate nerves and identify these neurofascial adhesions and entrapments to change the paradigm in how we look at nerve hydrodissection. So the rest of the story. In the neck, we have three fascial layers. We have the superficial layer that's mainly over the sternocleidomastoid and trapezius for our purposes today. There's a middle layer that covers the levator scapula and the rhomboids and the serratus posterior. And the deep layer, which is what we're going to mostly focus on, is covering our scalene musculature. And this becomes important because we have a fascial plane here. We have, this is trap, this is rhomboid, this is supraspinatus, and we have our medial border of the scapula. And in that plane, you can see there's fascial tissue from two of those layers. And I started looking at functional ultrasound to evaluate this plane. This is actually a person moving their arm in forward flexion and abduction. And you can see that the scapula punches a hole in the fascia. And that hole punch is not normal. Not everybody has that. So here's another patient with flexion extension. Here's our fascial layer. Here's trap. Here's rhomboid. Here's supraspinatus tendon. And look at the fascial thickening. And in that fascial thickening in here is packed with little nerve fibers. And so I developed this functional exam as part of my routine examination for scapular pain or cervical pain with posterior radicular pain. I'm doing abduction and forward flexion to sort of identify what happens in somebody that's punching a hole in that fascia with repetitive arm use. This is sort of a still shot. This is a very thickened and swollen fascial tissue plane, and this thing's packed with nerve fibers from the spinal accessory nerve. And so many of these patients come in with this sort of drawing, but more frequently than not, they all have a referral pain pattern down the hand to the first and second finger on the dorsum of the hand. And it's amazing how many people that I see that have that radicular pain pattern end up with a cervical fusion at C5, C6. They've all come in and got this fusion and say, my pain is still there, doc. Why? So again, as part of your functional exam, and I'm still trying to develop an understanding of this, how does the fascia, what's normal fascial gliding under ultrasound? How much is it supposed to slide? And how can I develop new techniques to evaluate that? And what new things do I need to learn to help push the bar higher in terms of this neurofasciopathy? And what new treatment options can we come up? There's some realizing that the hyaluronic acid is what lubricates that fascial layer. So here's an example of an asymptomatic side and a symptomatic side. You can see the fascial thickening here. There's the superior medial border of the scapula. And so you have to develop a side-by-side comparison. You have to start examining lots and lots of people to identify these small adhesions. Because you got to know what normal is. You got to examine all your normal patients before you can identify what's abnormal. And that's the challenge that we all have to ourselves is taking time out of our busy practice to scan the normal as well as the abnormal. So just a kind of here's our trapezius, and then this blue would be the superficial fascial layer. The purple is the middle layer, and here's our little nerve roots gliding in that pathway. So this is kind of my simplistic drawing of that, but this is the pathology in this patient. And so this is, and then I started saying, well, I'm seeing these thickenings, what should I do? I'm hydrodissecting the spinal accessory nerve in this fascial layer. When I just hydrodissect it right here, it helps a lot of people, but they seem to keep coming back. And why are they coming back? Well, then I said, well, maybe I need to hydrodissect that whole layer all the way up to it's high in the neck and the cervical region. And then most of those did really well too. And I'm like, what am I missing here? And then I went back to my brachial plexus and I went, oh yeah, the spinal accessory nerve in about 50% of people. You'll find that about half the patients that have shoulder neck pain have this variation where the spinal accessory nerve traverses. This video clip will go back here in a second. But there it goes through, and I'm now following this nerve, which everyone needs to be able to do to treat this disorder. You need to follow it all the way, and I now can follow it all the way to the scapula. And at first I couldn't do that, but I practiced, and now it's pretty routine. This is a hydrodissection of that fascial plane. And so this person, like my finger trap, had a restriction of the spinal accessory nerve here, but also at the superior medial border of the scapula. And so the treatment isn't going to be successful unless you treat both ends of that spectrum of disease. And then I was like, oh gosh, do I need to follow the spinal accessory nerve further in the neck? And then there's no book out there helping you learn the cervical plexus. I have a talk on that. I've been able to identify all the nerves in the cervical plexus reliably and have an hour-long presentation on that, which is really best for a workshop. But realize as part of the cervical plexus, I see people on a regular basis that have chronic vertigo, and I inject the greater auricular nerve, and their vertigo goes away. I mean, it's life-changing for these people. Lesser occipital nerve and headaches, chronic jaw pain that we treat with the transverse cervical nerve, and the supraclavicular nerve is an absolute must to learn if you're treating shoulder. And then again, the spinal accessory nerve has contributions from 2 to 4, so you need to be able to find 4, you need to be able to find 3, and be able to find 2, and look for fascial restrictions or abnormalities in those layers. And then adding to last year's concept, so we talked about the finger trap. Well, here in this patient, the C5 nerve root wraps around the anterior scalene. And because it wraps around, there's a lot of tension in this nerve, and the dorsal scapular nerve can be injured. And that's that tension in the entire system that I'm talking about. And it ends up being sort of Pandora's box. So here's the C5 nerve root. We're going to go back here in a second. Here it comes back, and it's going to go over the top of a part of the anterior scalene, and then it is deformed and compressed as it goes through that layer, and it's under a significant amount of neurostress. The question is what in the heck is happening to long thoracic nerve, which is also under stress because you got one nerve pulling it one way and another nerve in the other. And so, let's see, there it was right there. Sorry, I lost it. There it goes right there, long thoracic nerve and through. And so that's the challenges in these brachial plexus abnormalities or variations. You create significant tension through the nerve. So on this one, you have C5 wrapping all the way around anterior scalene. So that circumducts all the way around, and the nerve is under tremendous stress. And normally this hyperechoic band right here, right there, is where the long thoracic should be, and you can't see it well, so it's thickened and has a lot of fascial adhesions. Even though you can't see the nerve, the treatment is in breaking up those adhesions. So you have to know the fascial plane of these nerves. And in this one, this is actually a patient I scanned just a few weeks ago. I'll let it, this is 5, and 6 is right underneath it. They're going to twirl around. Here we are at the bottom. Let's see where we are. I'm not used to looking at these from the side. Here we go. These are the nerves, and they're going to twirl over and upside down, and 6 ends up on top of 5, and there's this huge amount of twirling tension to the whole system, and the whole system is under stress. And because of that, long thoracic and dorsal scapular nerve are under tremendous pressure. And then I was thumbing through an article, a small article on brachial plexus, and and they just in one sentence they said that there's a brachial plexus fascial sheath, and I'm like, what? Fascial sheath? I've never read that anywhere. And so I started digging and reading, and lo and behold, yes, there is. A prevertebral fascia not only wraps around the scalenes, it wraps around the brachial plexus. And that fascial sheath goes all the way down and attaches to the medial intramuscular septum of the humerus. And this is actually an older image where I'm hydrodissecting the brachial plexus nerve. But what in the heck is this little white hyperechoic line going all the way around the plexus? That's the brachial fascia. And so the brachial fascia surrounds the brachial plexus. And I go back and I can look at all these images that I've been taking over the years, and that brachial fascia is there. And so I'm like, oh my God, I wonder if that can create problems. And so as part of I had to learn how to do ultrasound of the plexus. I had to reteach myself to identify fascial planes. And so I now no longer evaluate just for the nerves. I'm not looking just for the nerves, I'm also looking for the fascia, because it's the fascia that's the key to finding the small branches. And so I develop a technique where I'm constantly pivoting and rotating and looking and following the fascial planes. I'm not trying to follow the nerve, I'm trying to follow the fascia. And by focusing on the fascia, all of a sudden, a whole new world opens up. You can start finding nerves that you didn't know that you could find. And so this example, I'm going to step back a little bit. By finding the fascia, I can find the dorsal scapular nerve only about 70% of the time. I'm like, what in the hell? Why can't I find it 100% of the time? And I'm the kind of person that doesn't like it if I can't be successful every time. And there's a small article out there in cadaver studies that show that there's a combined trunk of the long thoracic and dorsal scapular nerve seen in about 30% of this one cadaver study. But another cadaver study I found showed it came off C4 almost 30% of the time. And then another study I reviewed said it come off a C4 and C5. And so the challenge is if you're trying to find these nerve roots as they come off the major cords or the trunks, you may not be successful. It's all about the fascia. If you go to home base, which is your fascia, you can now start finding many of these small nerve roots that you couldn't find before. So this is an example of that. This is a long axis view of the dorsal scapular nerve going through the middle scalene. And the only way I found that was chasing the fascia. When I hunted and hunted and hunted, I spent years trying to hunt and get a long axis view of the dorsal scapular nerve, and I could never do it. It used to drive me nuts. Why can't I find this? It's because it's all about the fascia. If you start scanning the neck for fascia, all of a sudden the world opens up. And then not only do you need to scan the fascia, you do need to scan the muscles. And in this patient, they have normal levator scap on both sides. I'm not so convinced now that dorsoscapular nerve's involved, and I'm going to start searching for atrophy. I look here at the trap, I look here at the levator scap here, I don't see fascial thickening, maybe some fascial thickening here, but I'm not impressed overall until I get further along in this exam. Again, here's a fascial examination of the long thoracic nerve. This is the combined portion. So this is the C6 contribution, and C5 comes in and attaches right there. And again, I'm a little bit from the side, but those are the two. This is the C5 contribution, that's the C6. And so after a while, you start looking at these and start able to identify more and more of the nerves, and you can follow them down the clavicle. And a complete exam includes identifying the muscle. So this is an example of serratus anterior and an atrophied serratus anterior. What's interesting about this case is that the atrophy of the serratus anterior is only above the clavicle. And so if you start looking at the serratus anterior above the clavicle, it's atrophied. You look below in the thoracic area and looking for the inferior medial border, those muscles were all healthy. And then I was confused, like, why would it be atrophied up here and not down there? Well, this is an example of a long thoracic nerve. Here's our serratus anterior inserting into the superior medial border of the scapula. And here's long thoracic. It's a little swollen, but there's a black hyperechoic line right here. That's the branch to these muscle slips off the first and second rib. So when I hydrodissected this area, that little tiny nerve, I was able to resolve the scapular winging component of their pain. And so that's the bar. This is where we're raising the bar to in nerve hydrodissection, is to be able to identify, to use your complete examination, look at all the nerves from the brachial plexus down, evaluate the muscles, evaluate the fascia, evaluate all aspects, and then make a diagnosis on this tiny little subtle finding. That's the bar. That's where we all need to push each other in terms of our diagnostic and skills. And then this video clip drove me nuts for a couple years. This is the superior trunk. This is the suprascapular nerve. And you'll see it come here, and then it'll flip over something. Here it comes. And then it's deformed and flips over something. What in the hell is that? That drove me nuts. I couldn't explain it in any way until I read that one sentence, brachial plexus fascia. And this is an example of the nerve trying to exit out the brachial plexus fascia and becoming entrapped in it, and it's deforming it. And once I understood that, that changed the whole paradigm for me. Because now I'm sort of looking at nerves with the fascia. This is another example of a suprascapular nerve right here. And see how it blows up and then it goes back to normal. It has a fascial restriction. The fascia is causing the adhesion to the suprascapular nerve. You can treat this patient downstream all you want in a spinal glenoid notch, or treat prolotherapy to whatever, but until you address this, you may not have complete success. So it really becomes an example of nerve hydrodissection and fascial hydrodissection. So again, I now, when I work on the brachial plexus, I routinely hydrodissect from that fascial insertion into the medial border or the medial retinaculum of the humerus, and I blow the fluid all the way up under the clavicle and all the way across. And this is another example of fascial restriction. So this is suprascapular nerve right here. There it goes, and then boom, it blew up. And so that's after I released it, and the patient's symptoms improved. And then we actually had, this was a patient, somebody I worked on yesterday. They had lots of adhesions. So you can see here's the long axis, the accessory nerve. This is the humerus. Their arm is in an upright position as seen here. And you could see the fascia is thickened and the nerve is being compressed through this area. And so I'm taking a needle in and treating not only the nerve, but I'm treating the fascial adhesion to help solve the problem. So it's a chicken and the egg. I mean, is it the nerve getting stretched that creates inflammation, which creates fascial adhesions, or is it something in the fascia that creates inflammation entrapping the nerve? I don't have the answer to that. It could be multifactorial. It could be lots of things. And I think that's the challenge for all of us in terms of raising the bar. Why do these nerves get caught up in the fascia, and why do they get entrapped and cause pain? It's really all about putting the puzzles together, and I need everyone here in this journey. We all need to be looking and working towards finding the answer to this, because it's going to help a lot of people. There's a lot of amazing ultrasonographers here and excellent providers and many different skill sets. And when we all come together like this puzzle, by coming together, we can solve these neurofasciopathy issues. And then the future. There is no study on what's the best hydrodissection fluid. There is no study. We all have our cocktail. Should we be using PRP or PRGF, platelet releasate or lysate? Should we be doing an intraneural injections? I would love to I'd love to try a few in the brachial plexus, but I've been a little too puckery to think about that one. Placental tissue matrix. I had a patient that had drop foot, told they had Charcot-Marie tooth. For 12 years, he had drop foot. I stuck placental tissue matrix around his nerve after I hydrodissected it, and he no longer has a drop foot. He walks normal. And so there are things that we can do as a group and share these success stories and share what we've learned. If we all come together, we can push the bar higher and higher and higher, and no one person can do it alone. And should we be using bone marrow, adipose graft, exosomes, what? And then, my new hot topic is what happens if I dilute hyaluronic acid and add it to my hydrodissection fluid? I'd love to try that. I haven't yet, but I'm gonna. And if anybody's here done that, please talk to me. Oh my gosh. And what newer imaging techniques do we come up? I've showed you just a few of the newer imaging techniques that I've created because it frustrates me that when I can't find something. And so I spend hours and hours and hours learning a new way to do it. Well, I need your help in coming up with better techniques. Everyone here probably has a secret. How do we all come together to make our secrets known so that we can create better techniques? And then the Holy Grail would be better higher resolution probes that help us see more and more. And then shear wave elastography. I played around with this for 6 months. Boy, that's a challenge. I looked at it from a fascial standpoint, from a neurofascial standpoint. I looked at lots of different ways. Some days I'm like, oh yeah, there it is. And then some days I'm like, I don't get it. And so we need to learn more about this. We need to play around with it more. I think the more of us in this room that start looking at this, the more we can teach each other about this and push the bar even higher. And so the new frontier is really coming together to push the bar. And then finally, neurogenic thoracic outlet. I no longer believe that neurogenic thoracic outlet is simply that the nerve is being squished by the rib under the clavicle. I think it's a neurofasciopathy. The fascia gets inflamed, it becomes thickened, the nerves no longer slide and glide underneath the clavicle here as if they're supposed to. And with this fascial thickening, what treatment options can we have? What happens if we put hyaluronic acid in that fascial plane? Could we cure thoracic outlet? Oh my God, that'd be huge. How much does a thoracic outlet surgery cost? I have no idea. It must be $60,000 to $80,000 per side. And these guys love to operate. I have a patient that they had both sides done, and with a week apart, and he won't return her phone calls because she didn't get better. So I think we can do better than that as an organization. And then finally, this is, this young lady, I've talked to her several times. She's an anatomist in Arizona State, and she's on the same path. Can these anatomic variations of the brachial plexus cause neurogenic thoracic outlet. And this is a huge topic and area because we can help a lot of people that no one else has been able to help. And then back to my patient. Well, guess what? She had that windshield wiper effect with her scapula. This is me hydrodissecting the area. And then she also had a little pull-off avulsion of the serratus anteriors that comes into the superior medial border of the scapula, which I showed in the workshop how to do a new technique that I created to evaluate this area. But I want to learn your guys' new techniques or your new insights or your tricks. Those are the things that will push the bar. So I'm hopeful that we can all continue this collaboration and continue the new frontier of nerve hydrodissection.